All right, I have broken things down into 5 basic organ segments. I know there are a lot of them. I told you 3 years I've been working on this. Okay, but I also put some icons in so that you can see some basic facts about every case. So 37 of the 50 cases we will look at are motor vehicle collisions, and that will be designated with that green triangle. The other causes, well, we have the typical guns and knives. Actually, that's not a knife, it's a screwdriver. We have a soccer mishap, and then we've got a bull, a horse, a doctor, and a woman. So those are the potential, the sources of these traumas. I also went to the National Center for Biometric Information and pulled the expected mortalities for every one of these injuries. So you'll see that with each one. And then whether or not the patient lived is certainly an item of interest. So a deceased patient will be designated with that ghoulish skull icon. And then whether the radiologist actually made the call or not. Did they see the finding? That'll be a red X if the radiologist missed the finding, like Miss Oathmar used to put on your grade school tests. So what this ends up is we have iconized all these things for every one of these entities, and you'll see those at the bottom of the screen. So if you ever think, hey, did this guy make it? You just look to the bottom and you'll be able to see the icon. Everybody knows that horseshoe kidney is particularly predisposed to lacerations, other traumatic injuries. And this is just a great example of it. You can see this huge defect. It's a very thick parenchymal isthmus to this horseshoe kidney, and it's torn right in half, and there's plenty of extravasation and a lot of retroperitoneal hemorrhage associated with this. And here you can see the gap there and the hemorrhage arising from it. The thing that was interesting about this is on the delayed images, the collecting system is not disrupted. It's actually bridging that gap that's been created in the isthmus, right there. And in fact, look at that. I've even got a 3D later that will show that. So here on the 3D, you can actually see that opacified collecting system still bridging the gap there of the parenchymal isthmus. Great. Okay, so what happened with this guy is they took him to the angio suite to embolize the bleeding portions from the parenchymal injury. And in doing that, they actually tore that collecting system, probably just transferring him onto the angio table. And so now on this follow-up, you can actually see there is a collecting system injury with resultant excreted contrast collecting. Right, so there, he's losing contrast from there and from there, and it's forming this huge collection of excreted contrast. So that now is, in fact, a collecting system injury. You can just see wisps coming off of those two collections. And then when we do the 3D, you can see it no longer bridges that gap. Crazy. This guy was in the hospital for 6 weeks, and this was his follow-up. So they just left that collection and it's gradually resorbing. Right, so that is a horseshoe kidney with collecting system injury. All right, Anush sent this one in. It's a nice case that just shows the subtlety of perirenal stranding that should still catch your eye and direct you to get delayed images. If you see any kind of fluid density around the kidney, I have such an incredibly low threshold on this. There's even a tiny cortical defect there. It really looks like a renal laceration. And there's that tiny bit of fuzz right next to it. It's a pelvic kidney, so more at risk for traumatic injury as well. And you see it again here. That little bit of perinephric fluid density, that's enough, right, to tell you you need delayed images, right? And so they're the delayed images, and you can see that collecting system injury and all of that excreted contrast spilling out into the pelvis. So there's the original, and just those wisps of density on the right medial side of that pelvic kidney are all that you get But it's enough if you see any evidence of a renal injury to suggest, I think we need delayed images here. And there it is. It's really quite extensive. All right, so that's another collecting system injury. All right, congenitally obstructed kidneys, they dilate up and that parenchyma becomes so thin and friable that it's particularly susceptible to injury. So this is a congenital UPJO. I've also seen this with a number of other chronic obstructions, prune belly, right, where you've got these big floppy kidneys with very thin parenchyma and it's very easily injured. This guy was actually kicked by a horse, so it wasn't a small amount of trauma, but you can see there's the kidney all dilated up, almost entirely collecting system at this point. And there's just extensive hemorrhage both within the collecting system and surrounding that kidney. So you can see that now it's all just rim enhancement, and there is a focus of actual extravasation there. So, you know, this would be kind of overwhelming to initially open this up and to never have seen this. So I thought I would put that in there, that this, again, it's a chronically obstructed kidney, which without all the trauma and the hemorrhage, you probably could have called. But you open this one and say, what is going on here? And again, there's the actual extravasation. All right, this one dates back to my residency. I think this was probably in 98 or 99. And this is a very interesting manifestation, an unusual type of renal injury, which is, if you look closely, that right kidney, now there is extravasation there, you can see there's contrast, but that right kidney is in the corticomedullary phase. Similarly, the left kidney is too. The left kidney may be just on the cusp of the excretory phase, but you can still see both sides are in the corticomedullary phase, but there's some pretty dense contrast right there in the collecting system of the right kidney. There's a tiny bit that's probably excreted on the left, but that right kidney, when we go down, look at that. That column of contrast goes all the way down, pretty dense, through the whole right ureter and even into the bladder. So what this was an arterial laceration of the kidney that is bleeding into the collecting system. And this was incredible. We actually took this guy to angio, and I still remember they catheterized the right renal artery and injected it, and he saw it just right down the ureter and into the bladder. So it was direct arterial hemorrhage into the collecting system, ureter and bladder. That guy did ultimately make it. All right, here was the one I warned you about. This is a gunshot wound, and this is a renal AV fistula. And so it looks a lot like that renal artery avulsion that we saw earlier, where the nephrograms were asymmetric and you had the retrograde renal venous opacification. But in this case, those are bullet fragments there. You can see again the renal venous, you can just look at that and say that's clearly renal venous opacification, right? But here, you can actually see this is in the arterial phase, right? And right at that point, there is a communication between the renal artery and the renal vein that is resulting in arterial pressure, retrograde opacification of the right renal venous system. And in this particular case, of course, we're not going to see retrograde contrast coming down the IVC, right? So you don't see any retrograde contrast. And that's what separates this case from the previous right renal artery avulsion with retrograde contrast, right? The appearance of the right kidney is very similar in both of these, right? But this one's an AVF. That's incredible how tiny those vessels are, and you actually kind of have to intuit that communication there. All right, this is an intraperitoneal bladder rupture. So you can see the actual contrast spilling out through the dome of the bladder. Of course, these are mostly in the dome. You can see there's a little bit of gas above the bladder as well. Right there, and you can actually see it spilling out from the top of the bladder. It's pretty unusual to get to see the actual site, and there it is on contrast in the coronals. All right, so that's an intraperitoneal bladder rupture. Very nice extraperitoneal bladder rupture. Again, you often have to just kind of intuit the presence of these. There's extensive hemorrhage, and you can actually see the clot in the bladder right there, and its passage out through the anterior portion of the bladder. You can literally see the clot passing through the wall there. Pretty unusual to be able to see it that well. And of course, we've got SI diastasis as well as pubic symphysis, the typical pelvic fractures that are associated with that injury. So look at all the clot in the bladder, and then right there you can see it actually passing through the anterior wall. So you're looking at an extraperitoneal bladder rupture that can be diagnosed without doing a retrograde cystogram, which is pretty cool. All right. Next, we've got a urethral laceration, and these to me, sorry, I wave my arms a lot. In fact, Imad, our CTO, he actually has an icon of Kermit the Frog doing this. Whenever I call him, he says it comes up on his phone. So these do look a lot like extraperitoneal. Certainly the contrast gets out and around when you do a retrograde in much the same distribution that it does with an extraperitoneal rupture. And you can see they're layering clot there in the posterior aspect of the bladder. As you go down here, you can see there is extravasated or extraurethral contrast anyway, right adjacent to the urethra. And you can actually appreciate that better. So again, the typical pelvic fractures that you'll see with extraperitoneal ruptures as well. So you've got superior and inferior ramus fractures. This is best seen on the coronal, and it really is nice to have a view like this. So again, there is the contrast, and there is the defect in the urethra. Again, you usually have to intuit this kind of thing, so actually being able to look right at that urethral defect is pretty unusual. That's a very nice view of it though. And so there's the bladder clot. Now we're tracking the urethra there, and that's right where the contrast is spilling out of it, kind of left anterior aspect. And we'll look at that on the coronal as well. You can see there's a little buckle to the urethra. And you can see that bladder neck is not contiguous with the urethra. All right, that is a urethral laceration. This one was the fault of a woman. A penile rupture. This is a great view of a corpus cavernosus rupture. You can see it's not a perfect circle any longer, and there's actually a little bit of hemorrhage within the corpus cavernosus, and there's a great deal of penile edema just in the soft tissues surrounding it. So this guy did live, but may not have wanted to. That's a really good, what I thought was funny about this is I have an MR that matches this perfectly. I don't think that was necessary. All right, I mean, I think you can make the call here. All right, and this is kind of a disturbing case. This is a uterine rupture in a pregnant woman due to a MVA. And so you can see the fetus here is intraperitoneal, basically. And here is the uterus, and it's there in the lower uterine segment. You can actually see a clot spanning the defect in the uterine wall. So these are, I've actually seen probably 3 or 4 of these in my career at this point. You can even see overlapping sutures in the fetal skull, suggesting he's not doing too well either. And then there again is the clot traversing the uterine wall there. And look at the overlapping skull bones there. So neither patient made it here. And that is typical. The NCBI says this is basically not survivable. All right, so that is a uterine rupture.